Good morning, everyone. I see some waving hands. How is everybody? I hope everybody's good. I know you're muted. It gets crazy on Zoom. Like 73 people all talk at once. So hopefully everyone is having a great morning. My name is Byron Cordes. I am the chair for the conference and also the chair for the Alzheimer's board for this San Antonio and South Central Texas. So I want to first kick us off by introducing Greg Scudo. He is our brand new executive director. He comes to us with a ton of experience from the corporate world. He worked for two of my favorite stores, I think, in the world, Blockbuster Video and Radio Shack. I have spent much of my money in my youth in both of those stores. But he's been with the Alzheimer's Association for the last 5 years. He worked in St. Louis, Missouri, and ran that chapter, and came out to West Texas about a year ago to help with the chapter out there in El Paso. And now we get to have him here in San Antonio and as our Region 7 leader. So he's actually leading the entire state of Texas and San Antonio. So I'm gonna hand it over to you, Greg, and let you say a few opening words. Thanks.
Thanks, Byron, and thanks to all of you for joining us. It's my great privilege to be a part of the San Antonio and South Texas chapter, and to continue to build on the success that this chapter has had over the years. Today is a little different than our conference typically is, right? We've transitioned to virtual, which is an adjustment for all of us. For me personally, I talk with my hands. It doesn't look so great on a Zoom background, but we adjust, right? If anything I've learned in the past 5 months with kind of our new normal is that isolation is everywhere. We all get to experience it in a similar fashion to those living with Alzheimer's or dementia. So we have this shared community now that understands a little better what we do and why we do it. Today is all about education, about learning the latest and the greatest and in research, but also about adding tools to the caregiver toolbox. We're all new to this virtual format, so there's liable to be a hiccup here and there. For instance, we learned we should probably have music during the opening slideshow so that folks know that they're not missing sound. So bear with us as we move through this. We are learning as well. One thing I would like to point out is that everything that we do for our community with the Alzheimer's Association is done free of charge. And our entry point is our 24/7 helpline. So if at any point throughout the day you have questions that don't get answered, we're going to do our best. But if you have questions that don't get answered, or if you recognize a need, please reach out to us through the helpline. It's available 24 hours a day, 7 days a week. And the number, which we'll put into chat, is 800-272-3900. But with that, I'd like to say welcome, thank you, and I will hand it off to Dianne to introduce our first presenter.
Hello, everyone. So I have the pleasure of introducing our first presentation. I will have to say, Dr. Thomas Weiss is such a busy individual. He had to record this presentation, but he will be with us for the brief Q&A after. So definitely we'll get to see him. But Dr. Thomas Weiss has a private practice in San Antonio. He primarily treats patients with dementia, depression, and anxiety disorders, including post-traumatic stress disorder and obsessive compulsive disorders. He is affiliated with Clinical Trials of Texas Research, San Antonio, and has participated in numerous studies as principal investigator across a wide range of innovative treatment options. Dr. Weiss attended the United States Air Force Academy, earned his medical degree from the University of Texas Medical School at San Antonio, completed internship and residency at Wilford Hall, United States Air Force Medical Center, and fellowship training at Harvard, the Massachusetts General Hospital. He is board certified in 4 subspecialties: adult, addiction, geriatric psychiatry, and psychosomatic medicine. So I hope you all enjoy, and here is his presentation.
Good morning. Thanks for taking the time to attend the Alzheimer's Summit today. My name is Tom Weiss. I'm a geriatric psychiatrist here in town, and I'm currently working at Clinical Trials at Texas. The Alzheimer's Association has been incredibly generous in allowing me to present the Texas two-step. So, a little more confirmation here. Perhaps you've heard this in taking care of your loved ones. There's nothing that we currently have that prevents, reverses, or slows the progress of Alzheimer's disease. So there's a sense of hopelessness. And then that second declaration, everyone knows someone who's a cancer survivor, but no one knows an Alzheimer's survivor. And as we all know, this is an incredibly costly illness. These are some dated figures. As of 2020, the cost of Alzheimer's disease alone in this country is upward of $700 billion. It will definitely put Medicare out of business because this illness doubles every 20 years. It's a very lethal illness. 1 out of 3 seniors dies from Alzheimer's dementia. It's currently the 6th leading cause of death in this country and in developed nations. And then this is a very striking slide. Alzheimer's disease, for a number of reasons, happens to strike women far more so than men. And, you know, we're all very familiar with campaigns for breast cancer, wearing pink and so forth. But as you read this headline here, this disease kills more people than breast cancer and prostate cancer combined. So very lethal, costly, common illness. And here's a reminder of the cost. From diagnosis to death, we think is at least 8 to 12 years, sometimes up to 20 years. A nursing home is no less than $80,000 a year, so incredibly costly for the family. And the guiding beacon in all this is, as we all know, you know, research has really been active, up and running now for 30 years. So we have to continue to be patient. Just remember, Rome wasn't built in a day. You know, we didn't get to the moon overnight. It's a moonshot. So I know you saw these same figures or figures like this a little bit earlier. But I think the one that's particularly salient is that bottom block on the far right. And as you can read, it says, since 2000, so I'm trying to read here, deaths from heart disease have decreased by 15%, while deaths from Alzheimer's disease have increased by 89%. So this is, I mean, that single statistic kind of tells the tale. You know, we're all quite preoccupied with this global pandemic from a virus. Well, this is has been a global epidemic. And you know the statistics, every 20 years this disease doubles globally. So we're looking at 150 million people with this illness globally by 2040. Okay, it's that simple, and it's that lethal. So here's our outline for Research 2020 update. It's ambitious. We'll do a quick glimpse at the past, quick glimpse at the present. We'll kind of have a little futuristic piece here. We'll look at diagnostics, pharmacologic interventions, drug interventions, non-pharmacologic intervention, support, and takeaways. So that's our game plan. So very quickly, here's Dr. L.Y. Alzheimer, and there's his index patient, August Dieter, a 51-year-old woman that he saw in 1901. He hospitalized her, treated her for 4 years. She passed. He did an autopsy, and he recognized this very unusual pathology, and he presented it to his colleagues, but not much happened until the 1990s. But we're all very familiar with what he described. He described these beta amyloid plaques that are outside the brain neurons, and these neurofibrillary tangles that are actually inside the brain neurons. in the microtubules of the synapse, and these essentially destroy the neurons. And this is what it looks like in probably its simplest fashion. Here's the pathology. As these neurons are destroyed, the brain loses volume. And as you can see on the right in this diagram, in the, I guess, the 10 or 11 o'clock position, there's a very healthy neuron. I'm sorry, it's actually right, crosses the diagram in the middle. There's a very healthy neuron with a very healthy synaptic vesicle, and above it is a dying neuron. There's the plaque outside of it that's causing tremendous inflammation and destruction, and then inside the synapse, another type of protein is destroying that communication and nutrient network. So here's our present treatments. We touched on these earlier. I won't belabor the point. They're used just for symptomatic treatment only. There's pretty good evidence that they have an effect on symptoms, but it's not terribly long-lasting. And while they are approved for safety, they do have some tolerability difficulties, particularly in older people. You're very familiar with Aricept, Exelon, Razidine, and very familiar with the last medicine to be approved in 2003, Memantine. So this is our present treatment black bag of interventions. So here's an article that was published in Neurology in 2015. It's called The Future Alzheimerology, a very funny word, in 2020. So 5 years ago, they were predicting what we would have right now. So the first thing they predicted is that we'd be able to assess risk at age 50 for developing this disease, and then every 10 years update it. So to a degree, we can do that, to a degree, and it's getting better. So that's good news, so check that box. The second thing is in 2020, we really emphasize history from the patient, even if they're severely demented, history from the family, and we really rely on the neurological exam. That hasn't changed, that's remained kind of a foundation of diagnosis and history taking. The third piece is we'd be able to do a brief screen and, if necessary, longer neuropsychological testing. That exists now. The fourth bullet is everyone would have a gene screen on an Alzheimer's disease risk chip. Well, that sounds very 21st century. It actually sounds like it might actually be a privacy issue as well. But that doesn't exist, that Alzheimer's disease risk chip. Although I guess the idea to a degree would be helpful, but how we go about it is another matter. And then the fifth piece, this fifth prediction, was we'd have imaging where we could scan the brain, pick up amyloid beta protein, tau protein, and we could measure these levels. Both of these do exist now. The amyloid beta scan came into play about 5 years ago. We just got the tau scan about a year ago. The only trouble is they're quite expensive and difficult to access. And then the sixth prediction is we'd be able to draw our blood and actually look at beta amyloid levels. We're right on the cusp of that, but it's not ready for prime time. And then the last thing is we'd be able to take a specimen of cerebral spinal fluid and again look at these bad proteins, beta amyloid and tau, and measure their levels. That exists, but it involves an invasive procedure. So not bad predictions, but we'll take it one step further. Using that information, back in 2015, they said in 2020, we'll be able to take patients that don't have any symptoms and don't have any evidence of beta amyloid accumulation in the brain, but they've got high risk based on their gene or maybe on blood levels. So we'll treat them with the medicine that'll block beta amyloid. Well, that would be nice if we had such a drug. And the second level, patients, again, don't have no symptoms, but they have evidence in the brain on scanning that they got beta amyloid accumulation. They'd also get treatment, but as you see here, they'd also get a vaccination to prevent further development, a vaccine for Alzheimer's disease. Remember, this is the prediction in 2015. And then 3 and 4, these are patients getting a little more unwell. Patients that have no symptoms, but they've got evidence of beta amyloid and tau in the brain. They'd also get drug treatments and a vaccination and anti-tau treatment, which doesn't exist. And the last one are patients that are quite symptomatic in terms of memory and cognition, and they have evidence of both culprits in the brain, and they'd get this whole package. So a lovely paradigm, but doesn't exist. So here's our model evolution of Alzheimer's disease. I mentioned this earlier. We know there's a very long latent pre-symptomatic phase, maybe 20 years. First beta amyloid protein set up, then tau protein set up. Then we start to see some changes, that's MCI, and then that progresses, more burden of these bad proteins, and then actual dementia resulting in trouble with memory, with language, with recognition, with executive functioning. So here's our markers in terms of current research. We've got 4 markers. Genetic testing, that's DNA, brain scanning, cerebrospinal fluid, and then blood markers. And here's the state of the union. This is an incredibly complex slide. I won't torture you, but basically all of these are different markers that we currently have. And they measure, as you can see in the horizontal axis, the evolution of this disease from pre-symptomatic to minimal cognitive impairment to dementia. And each of these tools allows us to come to some prediction. And if you can put 2 or more tools together, that kind of maximizes prediction about where this disease is going. An enormously helpful tool is there's a very rare type of Alzheimer's dementia called early onset autosomal dominant familial type. It's less than 1% of Alzheimer's dementia. It declares itself very early, in their early 30s. It's completely fulminant and severe by their mid-40s. And it's genetically transmitted, and we know these specific genes that transmit it. And the reason this is a tool is we can now follow the family cohorts of these patients, look at their children and their grandchildren. We know they're going to get this disease, and we can use medicines that failed here earlier, probably because they were given too late in the illness. We'll now treat these patients and see if we can modify their course. So here's our little pathway. We can look at early onset to give us some clues. We now know if people have head injuries or they lose consciousness, that also accelerates the evolution of this illness. We know some other genetic risk factors, particularly apolipoprotein allele E4. We know that heart disease accelerates this illness, as does diabetes. And last but not least, at the tail end of this is a disease that the biggest risk factor is advanced age, probably because as we age, our cells have signals to stop cellular repair. So if we can figure out how to reduce that signal to stop cellular repair and keep repairing the cell, maybe we can also back off on this illness. So here's imaging. I know you've seen these. This is an MRI, but there's some important things to point out. Where we want to zero in is on this part of the brain called the hippocampus. This is the site of associational memory. And here's a normal brain. You can see that it's full of tissue. Here's the ventricles. They're quite small. This is a very healthy, a very richly endowed, tissue-rich brain. Here's mild cognitive impairment. We can now start to see early volume loss. The neurons are dying in the hippocampus. The ventricles are enlarging. We're starting to see some shrinkage. And here's Alzheimer's disease in full bloom. Hippocampus is really diminishing. Ventricles are larger still. So that's just a plain MRI. This is an MRI which is tagged for beta amyloid protein. So it tells us where the beta amyloid protein is. It allows us to kind of see the progression. And this is a PET scan. This looks at uptake of glucose in the brain. We know that with Alzheimer's dementia, as beta amyloid and tau start to destroy the neurons, they also reduce the ability of the brain to use glucose. So essentially less and less glucose metabolism. On the right is someone with frontotemporal dementia. You can see the very little uptake of glucose there. And on the left, here and again in the hippocampal areas, really dramatic reduction in glucose. So these are imaging devices that work well. Here's clinical trial development. We're all getting familiar with that due to the COVID vaccine trials, but it goes like this. We develop a potential medicine, we trial it in an animal model. We have animal models now for Alzheimer's dementia. Then we go through first dose in man, that's phase 1. These are volunteers that do not have Alzheimer's disease. We're just trying to determine if it's safe in man. Phase 2 trials, small trials with patients that have the disease. We've got a couple of doses, high, low, and a sweet spot. We want to see again if it's safe and if it works. And if it works, does it keep working? And then we advance to phase 3 trials, big studies, hundreds, even thousands of patients. We now know the target dose, and we want to follow these people for months, sometimes years. Finally gets approved by the FDA, meets all the regulatory requirements, has to get licensed, then has to get produced. This does not happen overnight. Here's the targets. I'll just simply have you draw a line from the 9 to 3 axis. You can see below that, what we've been targeting with enormous failure is trying to either reduce production of beta amyloid or clear it. Nothing's worked, or if it's worked, it hasn't been tolerable. So now we're going to look at these targets. Inflammation, reducing glycation, which are lipid products in the brain, reducing oxidative stress, and trying to increase the brain to be more plastic, more versatile, more resilient. Those are our new target areas. Here's drug targets and candidates, and as you peruse this, you can see in the far right there's approved drugs. There's a group of diabetic drugs that we thought would help with reduced glucose metabolism. They all failed. Down here at the bottom right, there's that drug Sola that got so much publicity, hundreds of billions of dollars, a decade of work, all a dismal failure, but again, probably trialed too late. Other approaches, anti-inflammatories, medicines to reduce excessive calcium. On the left, we kind of proceed through vitamins, supplements, nutraceuticals, and then up on the right, antioxidants. So long story short, lots of different candidates. And this will really dazzle you, please forgive me. In the center are approved drugs. The second concentric circle is phase 3, getting close to approval. And then as we go out, phase 2, phase 1, and you can see all the candidates in preclinical trials. Long story short, lots of hope, lots of promise. You can say, wow, there's probably 50 drugs in development right now. So stay tuned and we're wiser. Here's our targets again. Can we modify the disease? That's the primary one. Can we maybe enhance cognition? Can we do both and have combination therapy? That would be absolutely highly desirable. And now I'll kind of give you 2 drugs that are available for prime time right now. The first is a drug from China, GV971. This was approved last November by the Chinese FDA. We're about to begin global trials to see if it can be approved globally. This has a very unique mechanism of action. Long story short, it's an attempt to reduce bacteria in the gut and thereby reduce brain inflammation. Very well tolerated. It appeared to work better in people that were more demented. So this trial is about to launch in this country. Second trial is right down the street out of the Biggs Institute, UT Health. This is called the STOMP-AD study, kind of a clever name, but it stands for Senolytic Therapy to Modulate the Progression of Alzheimer's Dementia. Senolytic is a $10 medical word for, again, repair of cellular aging. So these 2 compounds, dozanatamib, which is a chemotherapy agent, and quercetin, which is a phenol nutraceutical, they both are antivirals. They both seem to have pretty terrific anti-inflammatory properties, and we've got some early information that this might be also, again, very promising. It's a 6-month study for patients with early Alzheimer's dementia. Lifestyle interventions. So you remember Dr. Bredesen. So here's something of incredible value. For a long time, the Alzheimer's Association has kind of promoted the big three, healthy diet, an anti-inflammatory diet, exercise, a very potent medicine, cognitive stimulation. Then we went to the big 5, then the big 7, the big 9. Here's a little example of that. So up to the big 9, but all this comes from a study done 5 years ago in Finland. It's called the FINGER study, and if you look closely, you can see a little fingerprint up top. So FINGER stands for Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. I can only say that once a day. And quite simply, this is a 6-month study with folks that had mild Alzheimer's dementia. Half of the patients got very impressive nutritional training, exercise training, cognitive training, and meticulous management of vascular disease. The other group got regular health advice, whatever that might be. So they were followed out, and what we saw at the end of actually a year is dramatic improvement in the folks that had the interventions in executive functioning, in information processing speed, and in memory. This is no drug. This is just lifestyle interventions, but very direct and very sustained. So now we're going to do the same thing in the United States, but we're going to be clever. We're going to call it the U.S. Pointer Finger Study. And this is going to have a much more diverse population. In Finland, it was a very homogeneous population, so we're going to have a lot of minority groups. And that's wonderful, because they're, as we know, most at risk for COVID. They're also most at risk for Alzheimer's dementia for a variety of reasons. So a big study, 2,000 subjects. It's going to last a couple of years. We're going to look at the same factors. Last but not least, we now know that there's some interventions we can do with sleep. We know that there's a system in our brain called the lymphatic system, which can clear beta amyloid proteins. We're trying to figure out how to magnify this symptom. And then, of course, as you well know as caregivers, there's just a long and growing, thank goodness, list of non-pharmacologic therapies, be they cognitive or sensory or behavior. So in conclusion, I'm going to ask all of us to be incredibly hopeful. We've all gone through just a bit of despair with the failed trials, but it was a learning experience. If you talk to the powerful and bright scientists that are leading this charge, they are expressing confidence. This is also now a global Manhattan Project. Everybody's tied in, everybody's collaborating globally. You can see that from the China study. Finally, we've got adequate funding. It took a long time, but when President Obama left office, it was written in Alzheimer's research gets $1 billion going forward. And last but not least, thanks to you, public awareness is increasing.
All right. Thank you so much, Dr. Weiss. It's great to see you.
Howdy. Thank you. Great to see you.
All right. Well, I know that, thank you. I think a lot of the comments, mainly a lot of comments in terms of they wish everyone had a doctor like you in terms of walking through the process and really understanding this disease. But I wanted to see, can you talk a little bit more? I know with what we have available now, kind of what people can look to in terms of looking at a diagnosis and what would be a route that they can take now that would better give them some of that clarity possibly?
Sure, and I hope I'm not being overly optimistic and unrealistic, but I think we're in better shape, and these are better days now, where one could go to their primary care doctor with complaints of memory, and I think they'll receive a much better evaluation than they may have received 10 years ago, certainly way better than 20 years ago, where I think the primary care provider will do lab, will do a quick cognitive assessment. I hope, I'd like to believe, maybe I'm fantasizing, that they'd order some imaging and that they would follow up with this patient and also refer them to the helping resources in the local community. Now, I say that, and here I am, I'm working in the big city, but I've had a chance to go out to rural areas and talk to primary care doctors, and I think we finally kind of reached, I don't know if the word is critical fusion, but I think primary care doctors now are addressing Alzheimer's disease in a similar fashion that they address hypertension, they address diabetes. You know, we want to diagnose it early, we want to manage it with what we have to manage it right now. We want to do what we can for the patient, for the family. We want to look at even some non-medical things, legal advice, advanced planning, resources. So I think one can now get a pretty decent evaluation just by beginning with their primary care doctor.
Great, great. Thank you for that. And I know some people have asked, I know you've been in the community here in San Antonio, have been doing this for many years. Even when I started, I have to tell you, when I started in social work and working in long-term care, you were probably one of the first that I saw that spoke about the disease and really helped me to understand. What drives you in terms of doing this work specifically?
Well, actually, I'm 120 years old. No. That's a very simple question, a very personal question. So my mom passed away from Alzheimer's disease in 1993 at the age of 75. My father passed away from Alzheimer's dementia in 2006 at the age of 90. My sister's 78. She's been in memory care now for the last year. And I am homozygous for both E4 alleles. So I'm personally invested in this illness in a lot of different ways. That's my simple answer.
Thank you for sharing that, Dr. Weiss. And I know definitely, I mean, I know that has touched a lot of our lives, but kind of understanding too that even though we may not have been personally touched, this is a this affects us all in terms of our communities. Can you talk a little bit more to I know with the clinical trials studies, kind of the importance of us all being involved. I think some people have the misconception that it's just, if you have the disease or, but healthy people that can get into studies. What is the important, why is it so important for all of us to look at clinical trials and studies?
What a critically important question, and your timing is impeccable. So last week, as you know, they had the Alzheimer's Association International Conference, I think in Amsterdam. Mm-hmm. And this is an annual event. They gather all the researchers and the providers and the bench scientists. And it's a week of information overload. And I was sort of knocked off my feet when Dr. Jeffrey Cummings made the comment that 90% of Alzheimer's trials are dramatically challenged by difficulties with recruitment. And it's very difficult to recruit for a variety of reasons. I think some people are fearful about research. Some people are hesitant to be considered lab rats, if you will. Other people are concerned that maybe they'll just be given a placebo and this is a waste of time. And I think there's certainly some of those points have some pieces of validity, but I just kind of think about simple things. When I was a kid, I think about polio, and if it wasn't for research, Dr. Salk wouldn't have been able to give us our first vaccine, and Dr. Sabin wouldn't have been able to improve it, and what was a horrible scourge is now non-existent. So it's just so vital that folks volunteer, and we need people that are in the pre-symptomatic or early stages, because most of the trials now are focusing on early detection, early intervention, early treatment. So even if you don't have the illness or think you have memory problems, perhaps you know someone that does, perhaps you can recruit someone. And I view people that volunteer for trials as, maybe I'm being a little glamorous here, but I view them as citizen scientists. I really do. They're not just volunteers, they're very special people. The studies are long, typically. I mean, the short ones are 6 months, the long ones are a couple of years. But we try and make the visits as efficient as possible. Many of the visits now are done virtually so that folks don't have to be transported. We provide transportation. We try to minimize all the invasive tests. We try to make patients as comfortable as possible. And I know that the staff that I've had the privilege to work with, they're incredibly compassionate and caring folks. So that, I don't know if I answered your question. I got carried away there.
No, thank you. Absolutely. Well, thank you, Dr. Weiss, again. Again, always learn so much from you, and can see your passion and the work that you do. I know that some people have asked, and we can probably get that situated later, but they would love the slides. So if you have those available, we maybe get those to the audience. But they were very interested in your slides and the information. And so I know we're close to the time of the end of this. Any last minute things you want to share? Any last thoughts before we?
Sure. Just like I said earlier, Mom was right. Get off the couch, go outside and play and exercise, eat your vegetables, and do your homework. And lastly, I'm going to wag my finger like my mom used to me. Get your flu shots. Okay.
Thank you so much, Dr. Weiss. It's always a pleasure to see you and have you here. Thank you.
Welcome to share the slide. Please do.
Thank you so much, Dr. Weiss.
Bye-bye.
Bye-bye.
Thank you.
Awesome. I'll jump right back in, and we want to thank Dr. Weiss so much for his time and his talent. Again, my name is Byron Cordes. I wanted to just kind of quickly address the Zoom format. I know this is new for lots of us. You know, this conference was initially supposed to be in March in person, and we had to pivot. I love that new word. We're all pivoting. So we had to, quickly kind of figure out some way to do this differently. So we've got, our great lineup that we had in March. We've just now got it virtually. So during the breaks, the screen will show you all the agenda for the day. We have, of course, Dr. Weiss. We have Russell Gaynor coming up to talk about how COVID and caregiving affects caregiving. We have a panel from UT Health talking about community-based enrichment programs. We have Dr. Carl Hill at 11:45 talking about diversity. For folks that need CEUs, by the way, continuing education, that's the only session that we've been able to get CEUs for. But we will have nursing and social work CEUs for Dr. Carl Hill's presentation at 11:45. You'll just need to email me. It's in the slides that kind of progress through. So if you can just make sure you email me, byron@sage-care.com, and I'll shoot you a link to a survey, and then we'll get you your CEU. It'll be a one hour continuing education for nurses and social workers. We can do certificates of attendance for anybody else. We will have some breaks, by the way. We have Dr. Yvonne Lozano, but after Dr. Carl Hill, and we have Maxine Vieira at 1:50, and she'll be doing a Spanish resource presentation, and she'll be doing it in Spanish. So we're really happy that we're finally able to do something in Spanish. We do have a few breaks built in. If we were in person, I'd tell you where the bathrooms are, but it's personal for you. So they're ahead of you. They're to the left or to the right. I have no earthly idea, but you know where your bathroom is. We have a 5-minute break before we'll bring Russell back on. And I do want to thank our committee. Again, their names are kind of in the slide deck that Dianne will be running. We have a very hardworking committee and a very hardworking board, by the way. I know we have several board members on this call too right now. And so we want to thank them all for their hard work. Our sponsors, again, in the slide deck. I'm sorry I can't go through them one at a time, but go take a break, and we'll meet back here in just a couple minutes and listen to my good friend Russell. Thanks.
Good afternoon. My name is Lakeisha Davis Flagg, and my mother, Gwen, has been a resident of Arden Courts, San Antonio for almost a year and a half now. As a retired Army Nurse Corps officer and as a public health nursing professional, I have a high standard, as most children and loved ones of those suffering from dementia and Alzheimer's. And the team there has just done an extraordinary job of caring for and supporting my mother in ways that my family couldn't. That sort of comfort and confidence that I have in the staff is very much needed, not just because of my mother's diagnosis, but because now we're experiencing a pandemic. And it was critical to me that the staff did whatever it took to make sure that my mother was safe. And they've done that. They've far exceeded my expectations. So if you are looking for a facility that is going to provide the support that you can't by yourself in your own home, based on my experience, I can tell you that they will exceed your expectations. My family and I, we can rest at night knowing that she's getting the care that she's needed and will continue to need. Not only are they looking at her current needs, but prospectively looking to anticipate and meet those needs as they arise, as her disease develops and continues. And I just appreciate them so much. They've been like family. They reach out. They have educated me in ways that I didn't know I needed to be educated. They have been supportive of me in ways that I didn't know I needed support. Because care for our loved ones, it really is a family affair. It's a family matter, and they are experts at that. So I'm honored to give my recommendation of Arden Courts. I'm also open to one-to-one recommendations if you feel like you need it. I just really believe in the service that they provide. I haven't found
This
anyone who
meeting
does it
is
like they
being
do it.
recorded.
And as I said, I am a nursing professional. I've been in the medical field for more than 20 years. And so, hands down, they're hard to beat. Their service is remarkable, their staff is remarkable, and their leadership and their management is phenomenal. So, yeah, Arden Courts, you can't beat it.
One of the things that we wanted to share with you is what Arden Courts is like inside the doors. It's because of the COVID quarantining and restrictions that are going on right now for the safety of everyone. You may not be able to go in and see the facility and see the environment that your loved one would be moving into. And so we would love to share with you a little bit about that. As soon as you walk in the front doors, it's very welcoming. There are cookies, coffee, water waiting for us every time, and the cookies are delicious. There's a little seating area that's very home-like, like a little parlor of a house or a living room of a home. So you feel very at ease when you walk in. It's not like an institution. But the most important thing to our family, and I'm sure to yours, is knowing that your loved one is in good hands and that the staff who work there know what they're talking about. And that was something we found very impressive. From the moment we walked into Ashley, the admission coordinator's office, she was armed and ready to go with lots of information that was specific to our dad's needs. She gave us a whole book on this Alzheimer's journey. We also were impressed to find that there are support groups that meet in the community every week. They have training for families as well as their staff. One of the resources that I've been trained in was a lady named Teepa Snow who does some videos online. And when I mentioned it to the staff here, they said, oh yes, we've done her training. And when we visited some other facilities, they had never heard of her. So that was just another good sign to us that Dad was going to be in good hands and these people know what they're talking about. The other fantastic thing is that most of the staff have been there 10 years or more. And that is just very rare to find in